Dr. Dunnick, who is, I think, no stranger to you all. But Dr. Dunnick, he grew up in a small town in Minnesota. After graduating from Bethel College in St. Paul, Minnesota, he attended ORU, or Oral Roberts University School of Medicine from 1981 to 1985. And then he proceeded to join the ORU Family Medicine residency, which he completed at the City of Faith Hospital, and he served there as the chief resident in 1987 and 1988. He then went on and joined the faculty at ORU School of Medicine, which became, in his image, Family Medicine residency program thereafter when the School of Medicine closed. He is currently the president and residency director of this program. There has been 34 graduates of the program, I'm happy to say, that are in full-time medical missionaries, so they're certainly providing an incredible service to the world through missions. Dr. Dunnick is board certified by the American Board of Family Medicine. He is a member of AOA, or Alpha Omega Alpha Honor Medical Society, Society of Teachers of Family Medicine, Oklahoma Academy of Family Physicians, Tulsa Academy of Family Physicians, and the Christian Medical and Dental Society, or CMDA. Dr. Dunnick has been involved in medical missions in numerous countries around the world. He's married to his wife, Lee, who is also an ORU graduate. They have a very large family of 6 children. I can hardly handle 3, so I admire him.
That's all I can handle, too.
Do what?
That's all I could handle, too, is 3.
That's a lot. 3 boys and 3 girls. He said as a family they served as medical missionaries at Mana Mission Hospital in Ghana, West Africa for 2 years, 1999 through 2001. And then in September of 2010, they moved to Kabul, Afghanistan, to help train physicians in the Hope Family Medicine Residency Program. And so with that, I would like to introduce Dr. Dunnick. Thank you so much, Mitch, for being here today.
Hey, happy to be here, Lance. Thanks for all that you do, and thank you, Becky. And I want to just start out thanking Samaritans Purse. Been a huge blessing to us as an organization, huge blessing to our graduates. We've had several people, I don't even know how many, have gone out under the scholarships, and I think we've worked together in lots of places, and I would hope even in the future more closely. So it's great, and thanks for taking the time to put this together. What I want to talk about today is really just some of the things that we've been involved in, maybe that I've been involved in. And we as an organization, it's not super technical, and it's not detailed about medicine, but it's in regard to patient care so much, but I think it is, and I think it's very integral to what we're doing. So I'll just get going and say, if anybody has questions, thoughts, ideas, comments, let's throw it out there and make this interactive. Before I go on, I'll just make sure, is everybody hearing okay?
We're hearing better. It's still not perfect, Mitch, but it's fine. It'll certainly work.
Okay, super. Well, as Lance said, I've had the privilege and honor of being involved in medical education and training resident physicians most of my career, and I really enjoy doing it. I see it as a privilege and an honor, and also a big job to try to help other young men and women who are called of God into the health field, whether it's as physicians or as nurses or PAs, nurse practitioners, anything else, that it's an honor to do it. And what I've learned in quite a few years of doing this is that if we only get the technical things right and we get the academic things right, but we don't get the principles and the values right, we do a real disservice excuse me, to some of the people that we're working with and some of the people that we're trying to train. And that's certainly true here in the U.S. as well as some of the other places. We lived in West Africa for a couple of years. I learned a lot there working with the physicians there, and more recently in our time in Afghanistan with the training program we had there. Obviously a different kind of situation with the Afghan physicians, but I think there's things that apply in all of these setting. So I wanted to share some of the issues of values and principles that are integrated into healthcare education, medical education, and just share some of my experiences there. So we'll step ahead here. Let me see about advancing this slide. So we're going to call this values-based training of physicians, and the emphasis obviously is international, but I truly believe that this applies in the U.S. and abroad. It's pretty global and universal as we look at it. The logo that you see there on the bottom, I'll just mention that briefly because it's not the In His Image logo. Hope Partnerships International is intimately linked with In His Image in our international relief work, and it's really our face outside of the U.S. that we do our international mission work with, whether it's the educational things or the clinical things. So it's a separate 501c3 that we've set up to run the international missions work. So just in case that question came up in somebody's mind, what in the world is that? That's Hope Partnerships, and I'm in the leadership of that too as well. So that hopefully that just clarifies that. Here's some of the core values that we talk about, and obviously there can be discussion about, are these the right ones, are they the only ones? But these are a current set that we're working with our international training programs, but we also use here in the States. And what we've said is that the staff and the faculty and the residents will adhere to the following core values: patient first, respect, integrity, stewardship, sanctity of life, lifelong learning, and excellence. And what I'd like to do is just go through those one at a time and broaden the discussion about them a little bit and see how they apply, and maybe even some examples of where they make sense. This slide, if you see this picture, this is in Kabul, Afghanistan. The name of the program there is Hope Family Medicine Afghanistan, and the ladies in the picture are all the female residents except for the one in the red. That's my wife, Leah. We were privileged to live over there for a year and took 2 of our 6 kids. They were in junior high and they went to school and had almost all Afghan classmates. The school was taught in English, but they got to do that. And then that's myself in the salmon-colored shirt. In the green shirt is Dr. Tim Fader, who I'm sure some of you know well. Just lived in Afghanistan for I think 8 years and is now working in East Africa. And then some of our faculty and the resident physicians. And the reason I wanted you to know this is because even though we were in Afghanistan, clearly in a Muslim-based society and culture, these principles applied, and these residents and faculty really bought into these as being core values that a physician should have when they're taking care of patients and when they're looking at patient care and when they're doing their work. So it applied there. We certainly use them in Ghana as well. Now the first one here is patient first. And this talks about our focus as healthcare providers, that the excellent care of patients would be our primary concern. And this runs in the face of a lot of things that go on both in the U.S. and overseas, that sometimes our primary concern is our own reputation, or it may be our own economic status, or it may be our political status, or it may be our own family. But one of the things that we talked about at length is that caring for the patient should be our primary concern. And one way to look at how well we care for them and what our attitude is toward them is that we care for them as if they were members of our own family. Our father, our mother, our brother, our sister, our son, or our daughter. This is it's interesting because on the surface, it's easy for the docs to say, yes, of course, that's what a physician does. But as we talk about it, and we talk about decision making, and we talk about quality of care, and we talk about going the extra mile and the effort that we apply to take care of the patients that come to us, this often would bring up some questions. So we were able to establish this value and said this is an absolute. I was recently in Afghanistan about 3-4 weeks ago, and I was talking to the young resident physicians over there, and it's a tough place. It's a chaotic place. It's a difficult place. There's a lot of uncertainty. Right now the program is even a little bit unstable because we run into some difficult funding issues. The primary funder of the program pulled out. So they're looking to me and say, what are you going to do? We need to be trained. We have a right to be trained as physicians. And I said to them, if your main reason for joining this program is so that you can get a certificate and you can get a good reputation and you can make a good economic living for yourself, then I'm not sure that you should be in this program. I said the main reason that we have come here to help train you is because we have love for the people of Afghanistan, and we want to train you to serve your people. We want to train you to help your people, and we want to train you so that you can impact the healthcare of your nation. And if that's what you would like to do, to really serve your people, then you should stay in the program. But if you're primarily here for yourself to get a degree or a certificate or a title, then maybe you should leave. Now that was quite straight talk, and it was quite sobering to them, and it turned the whole situation around from it's about me and my right to be trained and my ability as a physician to the idea that we're here to serve and care for our patients. And I do the same thing in our training program here. Unfortunately, in medicine, there are way too many egos that have gotten expanded and out of proportion, and we have an idea that because we're medical doctors and have titles and degrees that we have more value or importance than someone else, especially than our patients. And I tell our residents, right now you need to check your ego at the door. You're privileged to be educated. You're privileged and gifted with an intellect that can handle some of the academic rigors that are required to get into medicine. So your job is to learn and be excellent to serve, and you should serve your patients to the same degree and with the same focus and energy as if they were members of your own family. Brings up a lot of questions, but I really believe it's a core foundation as we go ahead and try to teach medicine. Number 2, we talk about respect. And this value says that we will respect all people, regardless of their economic status, their age, gender, faith, education, position, diagnosis, tribe, or culture. Those obviously, there could be other items in that list, regardless of something else. I'm sure that you all could help me expand that list or describe it. This tends to be a really important issue. This doesn't just say all patients, but it really means all people, everyone that we come in contact with. Our basis for this is saying that all people have value. All people have dignity. From our perspective, it's because we are made by our Creator, and we have every human being is made in the image of God and has that imprint of God in him, and that God loves every person, and every person has value. So we will respect all these people. In developing societies and different cultures around the world, this is a challenge. Economic status, there is a real, as you know, real tendency to serve better those who may be able to pay, or those who may be able to pay more, or those who are maybe in an economic situation and have the ability to purchase health care at a different value or something like that. So we have to care for the poor. We have to care for those who don't have economic means and not discriminate in favor of those who may be wealthier or more economically blessed. Same is true of age. In many of these cultures, age is a discriminatory factor. Often that the newborns and the children and the very young are discriminated against in favor of the elderly. So we should respect even the young. We should respect children. We should care for them very well, just like we do the elderly. In our society, I think we're having problems where there's a developing and an increasing disrespect for the elderly when they maybe lose their ability to contribute or to serve or to help in meaningful ways, but that we have to respect the elderly and the very young. Gender is obviously a huge issue. Different societies, depending on the culture, depending on the religion of the society, often men would be more favorably treated than women. I'm sure some of you have been in societies like I have where women are viewed at as inferior, as less valuable, as less important, sometimes even treated like property. I've spent some time in India, saw some just horrible situations. We know that even gender selection in abortion goes on in many places, but that women are treated as second-class citizens or not even citizens at all, and are owned or bought and sold, and that as physicians, this was a huge issue in Afghanistan. We said, no, we will treat women and we will treat females as valuable and as important as men and as males because they are human beings. That was a very challenging situation there and brought up a lot of questions. What about faith? What if someone comes to you for care, or what if you interact with someone who happens to have a different faith or a different religion than you do? And that could be true of any culture, a Buddhist culture, a Hindu culture, a Muslim culture, a Christian culture. Will we still respect people and treat them with dignity and honor, even if they have a faith that is different than ours? Very important. What about educational status? Will we treat the uneducated with the same respect that we'll treat the educated? What about position? Will we treat the cleaner, the worker, the manual labor person, the homemaker, the beggar, as well as we'll treat someone with a title in a leadership position, someone who has risen to a position of control or power? What about diagnosis? We added this particular category during the year that I was there because we had some situations where patients came in and their diagnosis made them very subject to discrimination. There were two situations that, in my experience, stand out quite blatantly. And when we lived in Ghana, there was a woman who had come in. She was married, and she was HIV positive, and then she developed AIDS. And none of the nurses in the Christian Mission Hospital wanted to care for her because they said she must obviously be a bad person and have a bad lifestyle because she has AIDS. Well, as we began to talk about it, I questioned her privately, and we sat and we talked and discussed, and the truth was she had been a faithful wife to her husband, but her husband had traveled and was not faithful, and now she had become HIV positive and developed AIDS as a result of the choices that her husband had made, even though she had been faithful to him. And when we discussed that with the staff, I said, how can we do this as healthcare providers, discriminate against someone who has done nothing wrong? In Afghanistan, we had a situation where a young Afghan woman was brought in, and she was pregnant, and she was not married. This, in Afghanistan, that's called an illegal pregnancy. And no one wanted to take care of her. No one wanted to help her because her diagnosis and her social situation were unacceptable in the culture of that society. I heard a story from one of our young residents about a young girl who had given birth at age 14, was unmarried, and they took the baby and they basically killed the baby brutally, and then the girl's sister actually attacked her, poured gasoline on her, lit her on fire, and she died because of what she had done, because she was pregnant without being married, and that was unacceptable and brought great shame on the family. So I talked to the resident doctors and I said, who is missing in this discussion? And of course they knew the man was just missing. I said, is there not a man involved here? How do we know what this young girl's story is? How do we know it was her fault? How do we know she made bad choices? And what about the baby? Did the baby have any wrongdoing in this whole situation? So they concluded that that was wrong, and that both the baby and the mother should be treated with respect and with good care in spite of the diagnosis. The next two, I think, are self-evident: tribe and culture. What family group are you from? What tribe are you from? In the African countries, obviously, there are many different tribes and different ethnic groups, but that's true in Asia, in Southeast Asia. It was very true in Afghanistan. There was 5 or 6 major ethnic groups, and there was a tendency not to treat very well someone who was from an ethnic group that was different than the one of the physicians or the nurses. Sometimes it was blatant, sometimes it was very subtle, but we agreed that that was unacceptable, that as a patient, those things weren't attached to them and should not decide how they should be treated, but they should be treated with the same skill, the same effort, the same respect as someone who might have come from your own tribe and your group. So let's move on to the next one. Everybody with me?
We're good.
Okay.
Sounds good.
Great. Here's another tough one, but a very key one, is integrity. And one of the ways we'd expanded that a bit was said that we agree to be honest in our work, paying particular attention to accurate medical records, statistics, and note-keeping. There is a great tendency, not only abroad, but it's certainly in international settings, not to document well, not to be honest in what we write down, not to have clear statistics about how many patients have we seen, how many patients have died, how many patients have lived, what are the true accurate reporting in regard to what we are doing in the hospital or in the outpatient clinic or in the community health center. Those numbers often are changed in order to look more favorable than they might be when presenting to other people or reporting on the quality of your work. Maybe someone doesn't see a patient, but they make a note as though they have. Maybe they didn't do a procedure, but they bill the patient as though they have. monetary gifts and bribes are a huge issue in these settings. And the hospital we're working in Afghanistan, we made it clear, no place for gifts, no place for bribes. It's unacceptable. And what I was told by the physicians there was that even though the government hospitals were free, that in order to get care when you went to government hospital, you had to pay everyone, starting with the guards, then the cleaners, then the nurses, then the housekeepers, then the physicians, if you actually wanted to get good care. And it would actually end up costing more for the health care received in a government hospital than it would in the private hospital that we were working in. Very important, because if we determine that the payment, direct payment from the physician to the physician from the family or the patient was required, that would affect the medical care we offered, and that would conflict with our values of respect for all persons, and it would actually alter the quality of care we're rendering. The last issue is also important. We will tell the truth to our patients, the staff, and our colleagues. The value of truth-telling is held much more strongly in our society here in the U.S. than it is in many other societies. And that was something that I had to learn, and I'm still learning. It's quite a difficult one, that it's not as important or as a highly held value in other cultures as it may be in ours, that you can change what is true, you adjust what is true, you adjust your response based on the situation. Now, that was quite a challenge when I sat with the resident doctors and I said, do you tell your patients their true diagnosis? And it was quite interesting, because it was clear that they didn't, and that sometimes the families and the patients didn't want to know. So it has to be handled gently, it has to be handled carefully, it has to be handled with a lot of wisdom, but that truth-telling is something that's very important to us. I heard from one of my African colleagues in discussing this issue, he said, if I don't tell the truth in what I do, in my interactions with my patients and my interactions with the staff, when I'm asked to write down something that's not really true in order to benefit someone else, how will the patients know that what I tell them is actually true? We run into that in the U.S. here sometimes when patients might want a prescription written in the name of a family member who has a pharmacy benefit instead of their own name in order to get the medicine. Or they might want a note that says they're unable to work or unable to travel so that they don't suffer any economic harm. We discussed that at length. Is it really true? Is it acceptable to lie or to be dishonest in order to get some personal benefit? And truth-telling in our work and our note-keeping and in our interactions and our conversations is an absolute value that we need to hold on to. At the same time, adjusted with wisdom and insight on how much to tell and who to tell it to. But what we say must be true and must be honest. Next one, stewardship. We will wisely use our time and talents and the material resources of the hospital. We will not take advantage of the resources of the hospital for our own personal gain or that of a family member or friend. This points to the whole issue of being responsible. One area that it comes into when we talk about time and talents is coming to work on time and staying at work and working while you're there and leaving on the proper time. That if someone has a contract and they have a salary, and we tell them your salary is based on the fact that you will arrive at this time and you will work until this time and then you will leave. If you come late or you leave early or you don't work while you're there, that's unacceptable, because you've given your word and you're in a contractual relationship that in exchange for the salary and benefits you receive, this is the type of work and the type of activity that you will be involved in. It can seem a bit harsh, and it's sometimes the work ethic is different in different situations and different cultures and different nations. But this is very important, so that when something is agreed on, both parties, both the employer who pays the salary and the employee who provides the work and the effort in response or in order to fulfill his side of the contract, it's done. In education, that might include your job duty today is to come to the lecture and to be on time and to pay attention. Educationally, we use that both here in the States and overseas. That's what you're paid to do. The second half of this, about taking advantage of the resources of the hospital, that it's not acceptable to take medicines home from the pharmacy without telling someone or without paying for them. It's not acceptable to take supplies, medical supplies, bandages, instruments, other things home without paying for them because they don't belong to you. That is stealing, even though you work in a hospital. That you can't, or that it's not acceptable to do a laboratory test on a family member or on yourself or on a friend without the doctor ordering it and without the patient paying the appropriate amount. Now, if the organization decides we will do this for free, we will not charge the patient for this, that's okay, but that the individual staff member, physician, even faculty, is not in a situation to take advantage of those hospital resources or supplies or materials for their own gain or even for the gain of a family member and friend. This brought up quite a bit of discussion about what we could do and what we can't do. Now, if someone owned their own clinic, then they're free to do what they want. But if you're working in someone else's facility, that's really a pretty major issue. Next one, the sanctity of life, and I think this is something we all feel very strong about. We will honor and protect life, which is a gift from God. You know, maybe this one should be number one, because I think it gets to the whole issue of why are we involved in healthcare? Why are we working with people? Why do people come to us when they are sick, when they are suffering, when they're dying, when they're going to give birth to a child? Why do they come? And it's because they expect that we as healthcare providers and as physicians and nurses and people involved in that will respect them, but we'll honor them and protect their life, and we won't do things to shorten life. We won't do things to end life. We won't actively terminate a life. Obviously, this points to the whole elective abortion issue, which is very common in many developing countries for many different reasons. It's very common in our country here. But that we will not actively become involved in terminating the life of the unborn child. That there's not a place for that. We will care for people. We will love them. We will support them. We will help them in the middle of the difficulty, but we won't do that, because our role as a physician is to honor life, to protect life, to view it as a gift from God and not actively end it. And the other side of the spectrum as well, or is important as well, what about the elderly? What about someone with a terminal disease? How will we care for them? How will we help them? What's our role in caring for someone who really gets beyond our medical skills or our medical knowledge or our ability to stop the disease process? We can talk about cancer patients. We can talk about people with, other terminal illnesses, be it infectious or cardiac or pulmonary or renal whatever kind of status it is, where does that situation come in? We had an extensive discussion about the role of the physician in death and dying while I was in Afghanistan, and that I put it up on the slide, and an hour and a half later we concluded our discussion on that we don't run away from that. We don't ignore the situation when someone's dying, that we have a responsibility to be there and to support and to love and to care for and to assist someone in their life, but maybe that we're even assisting them and supporting them in the dying process. The role of hospice and being a leader in hospice and a promoter in hospice, where people have the right to die with dignity, but that we're not going to be actively involved by either ignoring their needs, ignoring basic supportive care measures, or even giving a treatment or a pharmacologic agent that would speed up death. That we are here to honor and protect life. Very key value as we're making decisions and we're in the middle of some of those difficult situations. Next one, lifelong learning, obviously has a lot to do with being involved in the educational process, but this speaks to the issue that we as physicians and healthcare providers have a responsibility to pay attention to what's going on in our profession. That as new treatments, new medications, new diagnostic modalities come up, new knowledge is discovered in our area of work, that we have a responsibility to pay attention to that. That as a physician, I shouldn't be practicing with the exact same diagnostic and therapeutic modalities that I was taught back in medical school. Some of them obviously apply, and some of them are very pertinent to what's going on. But there have been new discoveries, and there have been new research come out, new information, and that as a physician caring for patients, I have a responsibility to my patients and to their families to stay up to date with things that are going on in my area, that I have that responsibility to them to practice at a high standard. Obviously, it has to be a standard that applies if it's, say, if we're in a developing country, a country with significantly limited health resources, there may be some new knowledge that is in the international I guess data and research, but it may not be applicable or available in their situation. But really talking about staying sharp, staying up to date in our knowledge base and our medical skills, and doing this in a lifelong situation, especially for those who are involved in teaching, that we must keep our skills up to date, but we must instill in the learners the heart and the desire and the absolute necessity of maintaining the skills and keeping up to date in this whole process, that we owe it to the people we're teaching, but we as physicians owe it to our patients and those people that we care for in this process. And the final one, which is probably more of a summation of all of these, that we will strive for excellence in every aspect of our work. What we mean this to be, and as I've thought about this, and I've kind of been reviewing these things, I think that last word even could be expanded a little bit from work to maybe in every aspect of our life or our lives, that as individuals, as physicians, as professionals, but even more as people, that we'll try to be excellent. Now, what that means is it doesn't mean we're going to get the highest score on every test, that we're not, going to be the one who blows the top off in-service examinations or board examinations, but that we'll be excellent in whatever we do, that we do it to the best of our ability. Brings to mind the verse that says, whatever we set our hand to do, let's do it with excellence, but let's do it as unto the Lord and not as unto men. And that would certainly apply in our professional setting. Let's become and remain excellent as physicians. But what about our social setting? Our interactions with our colleagues, our interactions with our friends, our interaction with our spouses. How do we have excellent marriages? How do we, if we have families, how can we be excellent as a father? How can we be excellent as a mother, as parents to our children? A very important part of our social network, and our parents and our siblings and cousins, extended family, but also those in our social settings, our faith settings. How can we be excellent there? How can we be excellent personally in psychological situations? Obviously in healthcare, just like other areas, there's a certain amount of stress, there's demands, there's pressures, there's responsibilities. How do we stay psychologically healthy? How do we stay emotionally healthy? How do we keep ourselves well so we can do the things that we need to? That's really important that we pay attention to that. The same is true in our physical aspect. Do we keep ourselves as the healthcare provider, as the physician, a worker, do we keep ourselves physically well? Are we setting a good example for those around us about good choices in our own lifestyle with food and exercise and things we do and things we don't do, so that our bodies are fit and well in order to carry out all the various responsibilities we have, that we can be in excellent health in that area. And then as well spiritually, that we make active decisions and choices to maintain our own spiritual health. Obviously, when you're teaching, depending on what the setting is and what the situation is, that has to be adapted. But I think for those of us that are talking about this, how do we keep ourselves healthy spiritually? Are we carving out time in our lives to pray, to seek God, to worship Him, to read good material or fellowship with other like-minded folks to keep ourselves spiritually and emotionally strong? Because of the demands of our society, and often in international settings, that's very difficult to do. And it's easy to get consumed by the work and the needs and the demands and the challenges, and that's very easy even in the profession of medicine. In the States here, there's a huge drift away from the spiritual aspects and the faith aspects of medicine, and we need to fight that. And we believe that that's a core truth and a core value in order to keep us well, so that we can really function in the role that we've been put in, and set a strong example and set a good example for those who are coming after us and for watching us. So that's probably a bit of a summation. I think this one may be for those of you that know about Stephen Covey's things. The seventh habit of highly successful people is to sharpen the saw. It's to keep yourself healthy and strong and well and fit in order to fulfill all the responsibilities that we find ourselves in. Last picture here. This is a picture, and Dr. Fader is talking to these. These are all physicians. We had 5 positions available in the training program, and had 85 Afghan physicians show up to take a written test, and then those who scored the highest we interviewed for the residency positions. The thing that shocked me was the strong desire, just the passion that these young physicians had to be educated in a program that had high standards, not only medically, but also high standards ethically, and with the core values that we had. We had these core values posted on the walls of the hospital and in the office of the training program. And they wanted to be in a program that they felt would train them not only excellently medically and professionally, but from a personal and an ethical and a values-based situation. And my contention is if it was something that's highly desired in that situation, that I believe it's really universal, it's global in its intent, and it's something that young people are really desiring, in spite of the way we see things changing in our society, that there's still a deep desire and need for truth and for values, especially in medicine, that people are looking for. So that's the end. We're moving along here, and I would just welcome suggestions, ideas, if there's any questions or comments from anybody who's listening.
Any comments?
Mitch, I did a parallel of your lecture, unknowing about your lecture with Tim Fader about 2 weeks ago. The Hippocratic Oath I brought in because of the audience I was looking at, but it's interesting that this talk came today.
Were you over there with him?
Yes.
That's great.
They gave me access to all the medical students there, and as well as some of the faculty. So it was a very interesting time.
Wow, that's great. What's your name, sir?
Dick Bransford.
Oh, hello, Dick.
You remember him?
Dick and Millie were just out here speaking to our residents this winter. So yeah, Dick's to blame. Dick's to blame for a lot of the things I'm doing. I'll put it that way.
Awesome. Very good.
Yeah.
One thing I was just going to, this came to mind is, this just reminds me, when you talk about core values, Mitch, we take it for granted, and you think, well, of course, I mean, these are essential, and again, we take it for granted, but a very poignant example was, I think over the last decade, we've seen tremendous abuse in our the financial industry. There's been incredible embezzlement and lying and extortion, and the list goes on at the great expense of others. And Wall Street, there's incredible knowledge there. It just people are incredibly well educated with MBAs and various degrees. But if you take away honesty, if you take away integrity, if you take away these core values that Dr. Dunnick has described today, you really lose everything, don't you? I mean, that really was a poignant reminder when Enron and these various organizations, they're world class. But if you take away their integrity, what is it worth? It's no value, and so I think. Well,
it's based on the assumption and the requirement that people will tell the truth, that they'll accurately report their earnings, their losses. That's a big assumption, and you're exactly right. You see what happens if people don't do that, the whole thing falls apart.
It does, and so medicine. My goodness, I mean. Finances are one thing, but someone's life is invaluable. That's another. And so you're right, Dr. Dunnick. I mean, it is critical that we apply these core values, that we put the patient in front of ourselves and our pride and our own personal interests. So, yeah, very, very, very good. Anybody else? All right. Just one second here. I'm going to read this. It says, not sure my microphone is working, but just say thanks. Great. Jenny, I'm assuming that is you. Or thank you for participating today. But Thank you. Mitch, thank you so much for a great presentation and a reminder of how essential this is as we practice medicine and we provide for care for the underserved.